Hi, this is Dr. Carl Leopson at the University of Arizona. You know, we come in contact with lots of practices, policies, and programs in the field of education, but we don't always consider where they've come from. And in this video, we're going to take a look at how a model that began in the 50s in public health moved to the field of mental health, then moved again to the fields of special education and general education, and became the framework for what we now know as positive behavioral interventions and supports and responsiveness to intervention. Now, folks in the field of public health will tell you, and rightly so, that prevention has been a goal of public health since the time of the ancients, and improvements in water projects and sewer projects. But our story starts in the 50s with the Commission on Chronic Illness, when they developed a 3-level system of prevention, in which the primary level would seek to decrease the number of new cases of a disorder or illness. Secondary prevention would seek to lower the rate of established cases of a disorder or illness in the population, and tertiary prevention would seek to decrease the amount of disability associated with existing or ongoing problems. From the 50s through the 80s and continuing, there was some growth and change in this model, and one example is Gordon's 3 levels of prevention that were proposed. And really one of the things that was included in this model was the notion of a cost-benefit analysis, that universal measures are desirable for everybody and good for the whole population, and that the benefits outweigh the costs for everyone. So maybe consider vaccinations as an example. Desirable for everyone, and the benefits outweigh some of the costs. Selective measures for folks who would have a problem that would still arise, say somebody would still get the flu, some kind of selective measures for folks who would still get ill even with universal measures, and then finally indicated measures for folks who would become chronically ill, and in the case of the flu, perhaps for infants and the elderly, who are more likely to be affected and become chronically ill from the flu. In the field of mental health, the Committee on Prevention of Mental Disorders put together their own set of preventive levels based on work in public health, and they were pretty similar. There's a universal, selective, and indicated preventive level. But they're all focused on mental health instead of general physical health. And there are folks in the field of special education, particularly in the field of behavioral disorders, who have a foot in both the fields of mental health and in special education. And some of those folks in particular are Herb Severson, Hill Walker, and Steve Forness. And in the 90s, they started to look at these preventive levels that were being promoted in the area of mental health and how they might use them to help reduce the incidence of behavioral disorders within the field of special education. Also in the 90s, Rob Horner and George Sugai, University of Oregon, took that model and operationalized it into what, if you're familiar with positive behavior support or responsiveness to intervention, has become the familiar pyramid, with a primary prevention level, a secondary prevention level, and a tertiary prevention level, meaning that at the primary level of prevention, there are good school-wide systems of behavioral support in place for all kids, and that should reduce the overall incidence of problems. There's a secondary prevention level for students who, even with good rules, routines, and physical arrangements at the school-wide level, continue to have difficulties. And then for students with chronic or intense problems, there's a level of tertiary prevention with much more individualized and specialized interventions. The National Center for Positive Behavioral Interventions and Supports was established in the late 90s. George Sugai and Rob Horner received a multi-university grant to implement this prevention model for behavior in schools, initially as demonstration projects, but then over the years across the entire country. And it's become one of the most successful projects promoted by the Department of Education. That's, of course, where I come in. I was a doctoral student who was lucky enough to be included at the end of my doctoral training as a research associate in the initial funding of the Technical Assistance Center on Positive Behavioral Interventions and Supports. And you can see how the levels of support still fit the universal, selective, and indicated prevention model from the mental health field. Well, now we cross over into another area of special education. Doug and Lynn Fuchs at Vanderbilt University were focusing on the poor outcomes for children with learning disabilities. And they were looking for another model to use for identifying kids instead of waiting until kids would fail in school. They were trying to think of a way that they could get to those students sooner, and they looked at ways to implement this prevention model. So you ended up with a pyramid for behavioral instruction and another for academic instruction. And so in the area of academics, there would be a universal level in which all kids would receive high-quality, evidence-based instruction. Students that didn't respond in that universal system and continue to have academic problems would receive more intense secondary interventions. And children with more chronic and intense problems would receive yet more intense academic interventions at the tertiary level. They also received a federal grant to develop the National Center on Responsiveness to Intervention. Here's an example of how the responsiveness to intervention model kind of uses that prevention logic to possibly identify a student as having a disability rather than the common way or the way that we traditionally identify kids in special education. One thing that is in responsiveness to intervention, there is frequent screening and frequent assessment. So let's say a student is assessed at the beginning of the year and they don't have any, their assessment doesn't show them to be at risk for reading failure. That student remains in the primary prevention level. Let's say, however, that student does show up at risk in screening. In that case, there's more frequent monitoring within Tier 1 or within the primary prevention level. If that student responds, then they remain in Tier 1 because it's successful for them. Let's say, however, a student wasn't responding in Tier 1, and we monitor them in Tier 2. We give them more intense reading instruction, and they do respond. Then they might remain in Tier 2 for now and eventually return into the Tier 1 environment. However, if a student has initial screening failures, doesn't respond well to instruction in Tier 1, doesn't respond well to instruction as we do frequent assessments in Tier 2, then that student would be identified for the tertiary level, or the most intense level of instruction, and possibly also referred in the area of learning disability, developmental disability, or emotional and behavioral disorders. Secretary Arne Duncan has mentioned positive behavioral interventions and supports and responsiveness to intervention many times. This is just an example in a letter on seclusion and restraints that suggests the implementation of positive behavioral interventions and supports in schools. The thing to understand here is that positive behavioral interventions and supports, responsiveness to intervention, and this prevention logic has also entered into the consciousness of state and federal legislatures and into state and federal law. In a lot of cases, the pyramid that was separate, that was behavioral and academic, has been reconceptualized as a single pyramid in which we provide primary prevention, secondary and tertiary prevention across behavior and academics in schools. And it's become more of a general ed approach than strictly a special education approach. It's no longer just an approach meant to identify kids as having behavioral disorders or learning disabilities, but as a way to provide a structure of instruction that should lead to kids having the greatest amount of success. If you had any trouble looking at any of the slides, I'll be posting them so that you can see them at my Prezi account and you can walk through and read some of these pieces at your leisure. But what we've covered today is that a public health prevention logic, this three-tiered logic, has moved from the public health system in the 50s through its development to the mental health field in the 90s, then into the areas of special education, the development of positive behavioral interventions and supports, and responsiveness to intervention, and finally into the field of general education, where these two systems, PBIS and RTI, are almost considered more general ed practices than they are special education practices.